Hello, fellow zebra hunters. Welcome to an episode of Diagnostic Atypia, an open book podcast where we work and sometimes stumble through real life clinical cases with diagnostic twists and surprising endings. I'm Mike Arcieri.
And I'm Andrew Sanchez.
And we're residency friends who are now brand new hospitalists fresh out of residency.
That's right, Mike. Podcast, attending life, it's all new to us. Anyway, I think we've got a great episode for you today. So whether you're commuting to work, cleaning your apartment, out on a run, or one of the few who listen to podcasts without multitasking, thanks for tuning in and let's get started with another atypical journey.
Please remember, the content of this podcast is meant strictly and exclusively for the purpose of education and entertainment. The information discussed in all episodes is not a substitute for your own clinical judgment. All opinions expressed on this podcast are exclusively those of the hosts and do not reflect the views of our employers or other affiliated entities. All cases discussed are HIPAA compliant with key identifying details changed.
All right. So our what do you even call this, Mike?
Icebreaker question. Andrew has an icebreaker question for us.
Our icebreaker question of the week, with absolutely no context given to the listeners, is what is your preferred working position? Is it in a sofa? Is it reclined in bed, reclined in a recliner, at a standing desk? What is your preferred working position, Mike?
Well, right now it's apparently in a room full of boxes. If this was a video podcast, you could see just moving boxes behind me here because we're gearing up for a move. But I think I'm a traditionalist. Just a good office chair, preferably one that can spin, so I can spin myself around when I'm getting understimulated. Yeah. What about you, Andrew? Are you a in bed kind of guy?
I used to be like a very diligent in bed studier. Yeah. I would say less so nowadays. Now you can catch me on the sofa because we got our greyhound and he's always lounging there. So usually I just sit next to him and he kind of gets close to me. We just hang out. But yeah, happy to be part of the swivel chair club in this moment right now. I do enjoy my swivel chair at the office.
It's the simple things.
So we'll hear from the listeners this week about that. But what do you have today, Mike? Do we need our legs this week for a swivel chair?
We would need a swivel chair this week because we're talking about lower extremity weakness. So certainly not a standing desk at this time. So I'll go ahead and give you some stuff. And I'm going to rely a little bit more on the history here. So I'm going to give you more history than maybe we normally would. And in terms of format, so it's going to be 3 aliquots and then a final aliquot that'll reveal the answer and a few teaching points after that.
Okay.
So we have a 70-year-old gentleman. He has well-controlled type 2 diabetes, hypertension, hyperlipidemia, pretty severe coronary artery disease and peripheral arterial disease. He's had a carotid artery CEA bilaterally maybe 4 years ago. And then also known severe lumbar spinal stenosis. He has bilateral severe neuroforaminal stenosis on an MRI a year ago. He actually has central canal stenosis as well. So bad it does have mass effect on the cord. But fortunately doesn't have any symptoms chronically that would warrant sort of a surgical approach at the time. So it's been managed conservatively, but it's pretty severe at baseline. He is coming in at the request of his primary care doctor after labs obtained for lower extremity weakness, which I'll tell you about in a second, revealed a CK of 6,200. So basically, this is an issue that's been going on for a year. That's why he had the MRI a year ago, which found the severe spinal stenosis in the lumbar region. It's been sort of chronically bad, and it's been managed actually at times with oral corticosteroids, but mostly just steroid injections in the lumbar spine with relatively good benefit. He, about 4 months ago, had one of those usual injections, did find that it improved his walking mobility like it normally does, but wore off faster than it normally does, essentially. And he then was seen 2 months ago with worsening lower extremity weakness and some pain in the thighs as well. Basically, his legs felt very, very heavy. He's actually noticed some edema in the legs as well. Not sure if that's just because he's sitting down more, but really unable to get up his stairs at all. And at this point, he has, very hard to get out of a chair. He actually, when he gets out of the car, he tells you he has to grab his ankles and pull himself to the left to get out of the driver's seat. He has no symptoms or issues at baseline. He can still drive because he has good peripheral strength. He's able to push the pedal down no problem. And at this point now, he's probably at 20 steps before he actually has to stop. And he describes weakness, says he feels like his legs are going to pop. It's a quote in the chart. And he also says that there's pain as well in the thighs, not all the way down to not below the knee, just in the thighs. I missed the chair a couple times, excuse me, when he's going to sit down because he can't really support himself in that last couple inches before he falls into the chair. So at that time, he has diabetic neuropathy. They increased the dose of gabapentin for him, and then actually got ABIs because he has this severe peripheral arterial disease we know about. And those were actually normal, surprisingly. He then is coming back to the primary care doctor earlier today. Same issues, not getting better, getting worse. Now really can't go more than 4 or 5 steps without having to stop. So he's essentially wheelchair bound. He doesn't actually have a wheelchair, which is why he's coming in now, because he really has lost all of his mobility. No loss of bowel or bladder. And otherwise, the symptoms are the same as I've described from the previous visit, just sort of everything's more serious now. It's still in the thighs. He has not noticed anything upper body, so no issues with really any motor strength, sensory in the upper arms. And he's able to sit up, from a supine position, so he doesn't think he's got a lot of weakness in his low back, core. And so I'm going to stop there, and that's kind of the first half, and then I'll give you the exam, but I want to hear your thoughts first on just this history.
Wow, super interesting. I think whenever I hear the chief concern weakness, step one is to take a good history and get a good sense of, is this someone who's feeling weakness at rest, which really defines asthenia and this really kind of systemic syndrome, or is this someone who has true neurologic weakness where someone is trying to perform some sort of neurologic task requiring the entire neuraxis, and basically things are going wrong. And I think he made our job very easy here in telling us that this patient is really having profound issues standing up now, getting upstairs, and really having a lot of mobility issues related to this. So I think we're certainly in that world, generally speaking, and this kind of evaluation of weakness. And I do like to try, I know the patient's really coming in with more lower extremity deficits. Just make sure we're not missing weakness in other places. And I think that's why Mike gave us a lot of history on, is there anything else going in the arms and in the back, anywhere else? Because there are these subtle areas and kind of manifestations of weakness that you don't really think about too much when people are coming in with weakness. Like people say, I can't stand up. But then if you don't ask about it, they may not tell you, I'm actually having double vision too, diplopia, or my eyelids are droopy, or I'm having trouble swallowing. So getting basically a full review systems for subtle manifestations of weakness just could be helpful, just to see kind of what sites in the body are being affected by this. So I think probably on second pass history for this patient, and sorry, Mike, I know you gave me you can correct me later on. I think the only thing we're kind of left with is does this person have a dysphagia too as a manifestation of, you gave me a lot of information pointing toward potential myopathy, which we'll get to. So maybe I'll just put a pin in that. And then the final thing is this person having any sort of orthopnea or hoarseness, or kind of stuttering voice, inability to complete a sentence. These are subtle manifestations, kind of respiratory weakness. But really, if I'm just going to take Mike's excellent history here, it sounds like we're dealing with weakness just in the legs. And we go down the neuraxis for weakness, and you say, okay, is this an upper motor neuron issue or a lower motor neuron issue? For upper motor neuron issues, that's brain and spinal cord stuff. And for bilateral lower extremity weakness, brain is very, very hard to account for that symptom complex. CP Solvers actually has an excellent schema on this, and the DDX for that is basically you have bilateral ACA strokes, pretty hard to get those at the same time, or you have some sort of meningioma right in the middle of the brain, compressing both parts of the sagittal space there that cause that. So pretty hard to get those. And then spinal cord is an issue and of interest in this patient, given the lumbar stenosis, and this is why they did this very extensive workup. We're basically looking for really probably acute on chronic myelopathy, because it sounds like we know that there's some degree of myelopathy and that the cord is being compressed a little bit. But patients with bad lumbar stenosis and this sort of core disease, we see this a lot, and the neurosurgeons they get a lot of calls about very stenotic spinal canals, and the question, hey, is this explanatory of the syndrome complex? But really, from their perspective, they see so much of this that it really has to be some sort of like true acute on chronic process to cause this. And I think what would point us more in that direction for a case like this, and for any case similar to this, is getting a bladder scan and making sure there's no urinary retention, and just asking the patient, hey, are you having a hard time getting all of your urine out? Are you feeling you have a full bladder after you are using the bathroom, or have any other incontinence issues? It sounds like this guy's been having those symptoms. I will say weakness too, as a manifestation of myelopathy and cauda equina syndrome, which is like really involvement of all of those nerves, really coming out of the end of the spinal cord. Weakness is a very, very late manifestation of those things. So this guy isn't saying he has any like paresthesias in the legs that we know of. Maybe he has some mild stuff from the spinal stenosis and the maybe some radicular symptoms, but like persistent paresthesias and sensory deficits, it sounds like he doesn't have that. Then we kind of expect that kind of early on. And again, we would expect some bowel bladder symptoms. And then finally, we would see weakness. So the story isn't really adding up for that. So if we move on to lower motor neuron causes, I mean, we know we have the anterior horn cell, the root and plexus of the spinal cord. We have the nerves. We've talked about neuropathy on the podcast before, the neuromuscular junction, and finally the muscle myopathy. And I think you gave us a lot of stuff up front, Mike, to really point us toward myopathy. When you see a CK that's elevated, your first question is, was there trauma? Did this person fall? Because we see a lot of people come in after falls who have localized trauma to the legs that releases some amounts of CK, and it just gets better. It's not an issue. I would say the height of the CK, it's all contextual. If this person had a pretty major fall, it could be pretty high. We know from compartment syndrome, like of one limb, as a result of a fall, you can have very, very, very high CK. So I wouldn't put too much stock in a CK of 6,000 saying, oh, this can't be traumatic, because you can have very, very high CKs just from trauma. But this is a guy who tells you, hey, I haven't really had a significant fall, and he swears by it in his history. Then it's suddenly very, very interesting, because then you're dealing with really atraumatic rhabdomyolysis, and that has basically the differential that we would use to solve the case. And I'll just say, as a new hospitalist who's been studying a lot of CKs this past year, I have been surprised by finding people come in actually with CKs of around 1,000, 2,000, really with no like clear inciting factor. Like I've talked to like a patient who's like 95 years old, and she was found at her bedside, like basically unresponsive, like sitting upright, but like not able to converse with their family. It seems like she was dehydrated, and she came in, her CK was 1,000, 2,000. I thought, oh, this is very interesting. And we gave her a bunch of fluids, and it got better, and nothing ever happened again. And I sent like a myositis antibody panel on her, because there's nothing else going on. And of course it came back negative, and it was all better. So I've seen these like low grade CK elevations pan out to nothing. But my first question, or I guess I don't know what number I'm at now, a question I'd have for the patient is, hey, when was your most recent fall, if you've had one, and kind of how bad was it? And see if we can correlate that with the degree of the CK elevation. If I could predict how relevant that will be, I'd say it's probably going to be a true atraumatic thing, because of your description that it's really more proximal weakness, which is really a characteristic feature of myopathy. Neuropathy, it can be proximal muscle weakness and kind of inflammatory neuropathies. But really classically, it's more distal. And when you say that kind of the legs are painful and edematous, it really kind of raises the specter. Is the muscle inflamed? And is there edema in the muscles from some sort of process that's causing a capillary leak in the muscles? So all that to say, I think probably you're taking us down a path of some sort of atraumatic myopathy. And I wonder, do you want me to give kind of a differential for that right now, Mike? Or do you want to give me a little bit more history next?
How about I give you a little bit of the history that you asked for? I'll give you an exam, and then I'll ask for the differential then. Okay, sounds good.
Sounds good.
So you had asked about dysphagia, none, respiratory issues. He's not noting anything, and I'll just say on exam, there's no concern. He's able to take a deep breath. He's able to finish a long sentence in one breath. No real concerns from that standpoint. No loss of bladder or bowel, and no urinary retention symptoms as far as he knows. No constipation, no diarrhea, no sidle anesthesia, all those sort of questions. In terms of exam, I'll say probably the most important thing to know is that he's well appearing and overall pretty robust in terms of his musculature, certainly for his age at 70. He's in good shape. Notwithstanding the thighs, which are significantly atrophied, it seems, compared to the rest of his body. Now, it's a little bit prominent because he has pitting edema up to the knee on both sides, but it still looks to be out of proportion to the rest of his, bulk on exam. He has intact muscle strength in the upper extremities and the trunk. And upper reflexes are normal, 2+, symmetric bilaterally. And the lower extremities, actually, he has good peripheral as well, 5 out of 5, dorsiflexion, plantar flexion. He gets a little bit weaker with knee extension and flexion, and then he's basically just anti-gravity for all the hip flexors, as well as AB and AD duction. He has 2+ reflexes, though, at the knee as well as at the ankle. No clonus. And he really, for you, is not able to get out of bed. He's not able to walk more than a couple feet with a walker. And he's describing both weakness and feeling like he's going to fall, and also pain in the thighs at the same time. And then he sits down and those things go away. No skin changes. You do a pretty good skin exam because you know that can run in the myopathy differential. And you don't see anything there. And I'm going to stop. That's the exam. And let me know what your thoughts are differential-wise.
Okay. I think we're in atraumatic kind of myopathy land, it sounds like. The proximal much greater than distal weakness here is very, very characteristic of myopathy. For distal predominance myopathy, just to kind of let the listeners know what that world looks like, because that is a world where you actually have muscle disease, but it's more so your dorsiflexing muscles, plantar flexing muscles, and wrist muscles are more affected than the other way around. Inclusion body myositis is one to keep in mind. And then there are some muscular dystrophies that can do this as well. The muscles in myopathy can be tender or non-tender. And I think for tender causes, as this patient has, you really think of really toxic etiologies and making sure this is not someone who's drinking a lot of alcohol and he just hasn't kind of shared that with you yet. I've seen patients come in after alcohol binges with very, very high CKs and painful muscles, asking about recreational drug use, particularly cocaine, as a potent vasoconstrictor, can cause muscle ischemia and painful muscle damage. And then for other toxic, painful causes, really your prescribed medications are kind of the final ones to keep in mind in the toxic category. So is this someone taking a statin? And that really blends into the myositis category 2, immune-mediated necrotizing myopathy. Is this person on immunotherapy, immune checkpoint inhibitor, myositis, or are they taking hydroxychloroquine? It sounds like this patient doesn't have lupus, so probably not. But what we know after the pandemic that there is like it's not really a black market. It's a very public available market for sale of hydroxychloroquine for not just COVID-19 infections now, but a lot of different infections. So that's something to also ask about too. So basically, a very good med rec will be required because, like our severely elevated transaminase case, maybe we just are missing some historical factor here that we just need to ask about. So just asking that MedRec and recreational drug use history will be important to make sure we don't miss any toxic causes of myopathy in this patient. Endocrinopathy is something to consider too. So, your thyroid disorders, thyrotoxic periodic paralysis, these are things to keep in mind. So sending not just that TSH, but free T4 and free T3 will be important. And for metabolic causes, I don't think we have the patient's blood work yet. This has been going on so long, I highly, highly doubt it's going to pan out to be something just showing up at the BMP, because really it sounds more like a subacute chronic process now. And someone coming in with like a critical hypokalemia or critical hypophosphatemia, I would expect that to really take off and something would have happened. This patient would have had a malignant arrhythmia if it was from that. So I'm expecting the patient's BMP will actually not show those severe derangements. And then really on the first pass analysis, really for internists for myopathy beyond those three kind of categories, endocrinopathy, toxic, and metabolic, is myositis, like inflammatory myositis. And these are these diseases, polymyositis, dermatomyositis. We already mentioned the immune-mediated necrotizing myositis. And we have antibodies that test for a variety of different myositis antibody diseases, very, very long list of diseases that we send routinely as part of a panel that I believe includes 11, at least at my institution, different antibodies in this category of diseases. We'd probably be sending those on this patient if we don't identify any of these endocrinopathies or kind of toxic causes. And, you mentioned very kindly that there is no rash. Some of these phenotypes, of which I could just say dermato because it's in the name, and what is this other one? Oh my gosh, I'm blanking on one of these antibody diseases. Several of them can do it. NXP2, there we go. NXP2 is one, and MDA5. That's what I'm thinking of. Those two can cause rashes, but I'm sure there are others that I'm unaware of that can do this too. But the absence of a finding is never as convincing as the presence of a finding. So I won't rule out those things. Just be a rashless person with one of those antibody diseases. But yeah, I think I'm just gonna sit on that for a sec, Mike. I have my note here on myopathy pulled up. I'm just gonna double check if I missed anything. And I know I got one more aliquot left too, so hopefully I can make some more progress with that. But honestly, just to review the workup, I think it would be those endocrine studies, the MedRec, the BMP, and then if that doesn't pan out, the myositis antibody panel.
That sounds great. I'm going to give you a mega aliquot now because it's sort of actually the second and third aliquot all together, but let's just do it all. So I'm going to start off with the almighty MedRec. So I'll give you everything. So he's on aspirin, he's on atorvastatin 80, chlorthalidone 25, vitamin D 10 micrograms. He's on chondroitin, glucosamine, empagliflozin 25, Azedia 25, gabapentin 600 BID, losartan 12.5, metformin 500 BID, and metoprolol succinate 25. So that's his list. And then I'll just give you the labs here. So the CBC, unremarkable. BMP is also unremarkable. His creatinine's 0.7. His lights are all normal, including the cations. His BNP, sent because of that lower extremity edema, was negative at 42. AST is elevated at 180. His last on record a couple months ago was 22. ALT is 210. Last was 25. His GGT is actually normal at 15. normal T and D bili as well. B12 was low, normal, but the MMA was normal. TSH normal at 2.4. And then interestingly, he got 3 liters of IV fluids and his CK remains in the 6,000s. CRP is 1.8, ESR is 16, which is normal at our institution. HIV, RPR were both sent negative, anti-Jo negative, ANA negative, hepatitis B, he's non-immune, hepatitis C antibody is negative. I'm also going to give you the MRI spine. Essentially, in terms of the spinal stenosis disease, so basically it just redemonstrates the same findings that we're seeing a year ago, but there's been no progression, changes, fractures. The cord still has that mass effect without cord signal. Really nothing to suggest that the spinal stenosis is the etiology here. And then he does have interval development of significant atrophy of the psoas muscles, visualized bilateral iliac muscles, and gluteus muscles. And this finding is seen on both sides. That's followed up with a lower extremity MRI to sort of scan the whole way down the thigh. It says there is an abnormal signal intensity within the right and left abductor longus muscles and adductor brevis muscles, characteristic for myositis. And these are bilateral findings. So I'll stop there. Mega aliquot. And let me know how that changes things for you, or if it does.
Wow. Really interesting. I feel like I'm wanting to take a pause and make sure I'm not getting too much momentum kind of toward a primary myopathy. I think the MRI is very reassuring. We know that the cord findings aren't stable, and I don't think that would explain the atraumatic rhabdo that we're seeing. So that's good. I think something in the weakness differential to keep in mind in this patient with PAD for weakness, because for weakness we have really like the classic neuraxis, which we walked through, upper motor neuron to lower motor neuron. But we learned from an earlier episode that I don't know if this is something that should be tucked inside of that axis, but I have it now in my notes outside of the classic neuraxis as a cause of weakness, is really like the vascular supply of all of these things. So for a patient with really bad PAD, I'm wondering if they have some sort of like aortoiliac disease with kind of chronic ischemia of the muscles that is basically causing poor supply to the muscles and really like chronic ischemia. And that would look inflamed on the MRI and cause a myopathy sort of picture. Anyway, I think it's probably less likely, but I just want to put it out there just in case Mike is throwing another vessel disease causing neuro disease case at me. But no, I think I haven't had many cases where I've seen muscles light up like this that have been anything other than myositis, which again could be toxic. And we have the medrec. And remind me, Mike, was there a statin on the list? I wasn't paying attention at the very beginning close enough. Was there a statin on that list?
Yep, he's on atorvastatin 80. You look back and see that he's been on that for about 10 years.
Okay, so yeah, even if you've been on the medication for a long time, this is someone who could have developed immune-mediated necrotizing myositis from that. So certainly sending that antibody, if it's not in the antibody panel that comes with the Jo1 and other antibodies that you sent. But yeah, I think we have a lot of momentum now toward myositis, and it's just going to be a matter of which one. And I think probably the most helpful clue for the final diagnosis is going to be the degree of the CK elevation and the distribution. So we know from the exam and now the MRI that this is all proximal. So I don't think this is IBM. IBM is well described. I don't think it's inclusion body myositis. But for the proximal ones, which is pretty much everything else, really to get a CK greater than 5,000, it needs to be some sort of necrotizing myopathy, which is basically going to be something toxic, which we've talked about, something autoimmune, which we've talked about in form of the statin-induced necrotizing myositis, or something like immunotherapy leading to this, which of course we know the patient isn't on. So I think it's probably going to be something else in this antibody panel. And if they're seronegative, certainly, because with a positive antibody test in there, right, clinical context, which this would be the right clinical context, someone who's having proximal weakness and falls, it would be diagnostic to have a high antibody titer for one of these diseases. But if he's seronegative, then suddenly, okay, well, if we haven't identified a toxic culprit, then this guy's probably going to need some sort of muscle biopsy. And I can tell you if the specimen is showing necrotizing myopathy, that the pattern of autoimmune infiltrates and basically stratify this person into dermatopoly, some other sort of myositis. So I feel like that's about as specific as I could get, Mike. I hope I'm on the right track. I look forward to seeing what you're going to teach us today. And please tell me that they didn't have aortoiliac disease.
I really like that thought. I can't say that we considered it much, so kudos to you. Fortunately, that doesn't look like that's what ends up going on. Although we did not scan or evaluate for that disease. It's a good thought. I think our thinking was sort of that it's bilateral and it seems to be in the muscles, so it'd be, we're sort of exactly like you did, went for the fishing expedition in the muscles themselves. So what's important to know, I want to be authentic here, is that there's timing oftentimes, right, with anyone who comes into the hospital, and actually sort of a management question for you, because these things don't come back at the same time. So basically, he is seen by neurology, he's seen by rheumatology, and we already stopped the statin on admission. His weakness has improved pretty impressively with just stopping the statin and giving IV fluids. He's still weak, still needs physical therapy, but definitely able to get to the bathroom and back now, he was basically bedbound, just 2 days ago on arrival. What's interesting is that the CK has not changed, so it remains 6,000 at this point. I'm like, all right, let's back off giving liters of fluid every day, guys. I know the BNP was negative, but let's not make it positive. And really not fluid responsive. So that's sort of where we are because of that, and we're waiting for things to come back, and of course they don't. Rheumatology and neurology actually would like us to obtain a muscle biopsy, and so we do actually pursue that biopsy. And I'm just going to read it to you because I think this is kind of where things are interesting here in this case, having this pathology information before having all the answers, maybe in the wrong order. So I'm going to, it's a book here, so I'm not going to read all of it to you, but basically he has muscle fibers, moderate variation in size, frequent rounded, atrophic fibers, several degenerating fibers, including some myophagocytosis, and regenerating fibers also noted. He is noting also, the pathologist, that there are it's posse, inflammatory posse immune cells. He's got most of these macrophages, actually, not a whole lot of lymphocytes, no neutrophils. Those macrophages are CD68 positive. And other than that, actually, there's no necrosis that's mentioned on this. So there's no myonecrosis. We reviewed it with pathologists and says, no, these are my findings. There's truly, I don't see any necrosis on this imaging. And it actually recommends an EMG. And so I think I just want to stop there. The guy at this point is requesting to go home. PD's actually cleared him for home. That's how much improvement he's made with just discontinuation of the statin. We've done nothing else. But his CK is still in the mid 6,000s without any explanation, obviously, or change. And the question really posed to me is, do we send this guy home and wait for workup outpatient? Because things are cooking. The whole myositis panel was sent off exactly like you asked for. But we're told, we use Quest and it's going to take us at least a week. So what would you do here? And then I'll give you the final aliquot here, the final stuff.
Ooh. Oh, I'm so excited to hear the outcome of this. Here are my thoughts. If this were some sort of necrotizing immune myopathy, and we did nothing about it because we haven't given this guy any sort of immunosuppression, having had a patient with this briefly my intern year, this guy's disease would be like taking off. This would not be getting better. And you can have patchy disease on muscle biopsy where you're not catching all of kind of those textbook pathology findings for what you're looking for. So that's not to say the absence of these pathology findings means we're not dealing with that. But I think in this context of, I mean, I know the CK is still elevated, but it's not getting worse. And he clinically, he's like feeling better too. Like he's walking around now, it sounds like. I don't think that really fits the idea that we like missed some sort of ongoing autoimmune myositis. It makes me wonder, since we now have this temporal kind of improvement with the statin, the statin administration, is this somewhere kind of in the middle where it's not an autoimmune necrotizing myositis from a statin, which is the most extreme form of it, but is it in the middle? Is this just like toxic myopathy? And we're seeing damage to the muscle fibers without frank necrosis, and that's why he was weak. But it's not causing that like that truly pathogenic antibody where the muscles are necrosing and the whole body is getting worse, and they're getting like kidney failure from how much CK is being released. Like it's not really giving me that sort of flavor anymore. So honestly, I think I would send him home, close follow-up, like 1 to 2 weeks, see where his CK is, make sure he's still walking around. Okay, of course, we already know the myositis antibody panel is cooking, and see how he does. And I wonder if he's just going to get better. And I wonder if this is a DX atypia, why this is on DX atypia. This is just statin-induced disease, but not quite at its most extreme end, just somewhere in the middle. And I've never had a patient like this, so I can't wait to hear from you.
Yeah, those are fantastic thoughts, and I think exactly where my head was at, where our team's head was at. Of course, you have to talk to your consultants before you discharge people who you've consulted them on. And Neuro's fine with that plan. They're not super thrilled about doing an EMG. They think this is statin myopathy, like you said, toxic statin myopathy, not immune mediated. And Room, though, says, wait a minute, the CK is not coming down, and we should see it come down. Maybe it's not going to come down as fast as we'd like, but we really should see some response. And the fact that despite discontinuation of the statin, something's still generating that CK means that we should probably take the possibility of an autoimmune disease more seriously. I'll be totally transparent. I was not thrilled about this plan. I felt like giving high-dose prednisone to a guy who has myopathy felt unwise. Could give him another problem, right, and complicate his recovery. But ultimately, that's what we did. And then the plan was for follow-up in a couple weeks, just like you said. So I wanted to do the same thing you just recommended. Room wanted to add steroids. So that was the plan, was steroids and then close follow-up. Of course, we don't have anything back at this point because it's not been 7 days. Hospital is very happy with my length of stay, I suppose. And so I'm going to give you the final aliquot now. First, he has a CK in like 4 days or something like that, less than 7 days, excuse me. And his CK now has actually come down a lot. It's like in the low thousands from 6,000 a couple days prior, less than a week ago. And I think most importantly, his myositis antibody, which of course you said was going to be the key here, and it was, is his HMG coenzyme antibody was actually 142, and the upper limit to detect is 20. So markedly elevated. Room does follow him for what they, believe is immune-mediated necrotizing myopathy, and begins IVIG to try to get him off of the steroids because his diabetes, of course, is getting worse now that he's been on this high prednisone. And I'll just follow up that I keep an eye on this patient pretty closely in the charts, and he at this point is totally back to his baseline functionally. So he has some of that lumbar pain, but out living his life, walking around, going for drives. able to get out of a chair on his own. So
Wow.
big win for the patient. But
Wow.
had some teaching points, but of course, always want to hear your reflections first. But you mentioned this right from the beginning and all the way through. So absolutely kudos to you.
Oh, well, I've seen this before, but I haven't seen it behave like this, where it was fluctuating a little bit. Like he hadn't gotten treatment and he was subjectively a little bit better, but that CK, good on the rheumatologist. Super interesting. And yeah, I think first reflection, utility of the muscle biopsy, we didn't see necrotizing myopathy. And I imagine the pathologist did not read that as like consistent with immune mediated necrotizing myositis. So you can miss things, like he had very diseased thighs and psoas muscles, but if you just take a single piece of tissue, you can certainly miss those sort of like textbook findings. So something to keep in mind. I've kind of been through that dilemma before. Won't forget that. And yeah, I think the principle of CK greater than 5,000 really kind of narrows your scope. Has to be something necrotizing. Has to. That was the dilemma here, though, of toxic versus autoimmune, like via statin. Both of those hypotheses could have played out. And yeah, I think just like our last episode we recorded, management dilemmas, people do things differently. It's very funny, Neuro and Room had different opinions. This is just real life. Things are messy, and sometimes the safest thing to do is the right thing to do. And if Room thought, hey, this guy's CK was gonna take off and maybe his kidneys were gonna get shot after we sent him out, I think that's completely fair too. Yeah, I love this case, Mike. And also this brings back a lot of memories, and we're going to have to share this with the friends who took care of our Yale patient who had this disease.
And I think that patient who I also took care of, I think he was the reason that it was so discounted in my mind, was that he doesn't look bad enough. And the quick turnaround with the cessation of the statin, it just didn't really fit. So I exactly. I just didn't fit the illness script that I had in my head. And I had to sort of incorporate this in now. And it doesn't fit the illness script that I think most people have, and that, quite frankly, the boards have. But the antibody is extremely specific. We're talking greater than 90%. So that is most likely the diagnosis here. And maybe he had some toxic statin myopathy on top of it in the background, but who knows? I wanted to provide just a couple quick teaching points from the case. First one is that immune-mediated necrotizing myopathy, IMNM, has basically three groups. There's the anti-HMG antibody myopathy. That's the most likely statin-related, but I actually have an interesting caveat to that in a second. There's anti-SRP, which has a very dismal prognosis, and then auto antibody negative, which Andrew mentioned. And exactly like you said, in the right clinical context, you don't need a biopsy for the first two. But if you were to find that both of those things were negative, the whole myositis panel is negative, you don't find anything else, then of course you need to get a muscle biopsy, because that's how you would make the diagnosis of the third category, the auto antibody negative. Excuse me. That brings us to the biopsy. So there are sort of big three biopsy findings in IMNM, and the first, of course, is prominent necrosis and regeneration of muscle fibers. This is the hallmark feature, and kind of this is the thing that everyone's looking for. The other things to know, though, is that there's usually minimal or absent inflammatory infiltrates, so it's posse-immune. And it's when it does have immune cells, they tend to be macrophages, and they tend to be CD68 positive macrophages. And then there's also myophagocytosis as well with those macrophages. So interestingly, he did actually have the second two, right? He had the CD68 positive macrophages. He had myophagocytosis. He just didn't have the necrosis. And so, interesting, right? Because, and exactly like you said, for unclear reasons, 25% of patients with this condition have negative necrosis on biopsy. I'm sure a large chunk of that is just sampling error, right? Because it's patchy. But there may be other reasons why people don't have necrosis, but that's how I thought about it as well. It was just sampling issues. And but he had the other two, right, which I didn't even look for. My eyes just glossed over all of it. I was looking for the diagnosis I wanted. I didn't see it, so I X'd out, right? So, and then the last thing, kind of going back to the first thing I mentioned, is that statins are found in some foods, particularly the oyster mushroom and red yeast rice have naturally occurring statin compounds in them. And so not taking a statin doesn't necessarily mean that you don't have statin exposure. There is this kind of unexplained preponderance for a higher incidence of this in Asian populations. And the thought is specifically people in Asia, not people of Asian descent. And the thought is that maybe this oyster mushroom and red yeast rice are apparently more common in those cultures and those regions. And so the thought is that maybe that's increasing the base rate of exposure. So I thought that was interesting. I have no idea how accurate that is, but that was something. And I learned that from the rheumatologist on service. And then it sure is on it's on all of the websites as well when you're reading about these things. So those are my thoughts. Andrew, any other thoughts on your end?
I just love that we're adding on to our exposure history through this podcast. Sir, do you live near any like production facilities where there could be some arsenic in the water? Eat any oyster mushrooms, sir? Yeah, Mike, we're not going to be able to get through our history in like a year. Our list of questions is going to be too long. No, this is such a good case. Thanks for bringing it, Mike. And I think it's really cool that we were able to compare this to that old IMNM case that we had together that was so dramatic. We could drop a link to that on the website for sure, because that was actually published. We can show you that. But yeah, thank you, Mike.
Thank you, Andrew. Fantastic job.
That was a fun one, dude. That was really fun.
This has been Diagnostic Atypia with Drs. Andrew Sanchez and Mike Arcieri. The show is produced by us with the help of Podcastle. Our intro-outro comes from the album To the Surface by pianist Lawrence Fields. If you enjoyed this show, consider subscribing and sharing our episodes with others. If you have your own atypical diagnostic journey to share, please reach out to us, dx.atypia@gmail.com. We'd love to discuss it with you, and we welcome medical students, residents, and even seasoned attendings. Happy zebra hunting. We'll see you next week.